The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey folks, Eric back with you. Today we're going to do a really cool podcast. Got a pediatric case. This is going to be a nightmare series case, and I think you'll find this case to be very complicated. I've ran this by a few different doctors, and this is a very tough case, and I think there's a lot of cool, really relevant teaching points that we can talk about. Before I get started, I just want to welcome everybody back to the show. If you're a frequent listener, again, we really thank you for partnering with us, for subscribing. That really does help us. If you're new to the show, this is the first time you've listened, you just open this up, we really encourage you to subscribe. We appreciate you partnering with us. We understand that you can go somewhere else for your education, and we hope that we build your trust. I want to thank everybody for downloading. I want to thank everybody for steps to broaden your knowledge and just understanding that we all need to constantly fill that cognitive tank. This show, as you know, if you've been a longtime listener, is highly practical, and it is very easy to leave the podcast and go and apply these concepts to your everyday clinical practice. You know, whether you're a ground paramedic, whether you're a nurse practitioner, whether you're a doctor, a flight nurse, flight paramedic, whatever your discipline, we know that filling our cognitive tank constantly is essential. This show is all about answering your questions, and the FlightBridgeED team, including myself, my wife, Clint Klepping, Bruce Hoffman, Mike Verkest, and Evan Claunch, we all are here to serve you in one capacity or another. So we really appreciate your time and for partnering with us. All right, so let's jump into the podcast. You have a 28-month-old male patient, approximately 15 kilos. You're called for an interfacility transfer. You arrive on scene and you walk into the ED. You see family outside the door. The patient is actually inside, currently being intubated by the physician. As you walk in the door, you note that the doctor has just passed the ET tube successfully. You walk in, assist with securing that tube, and you start getting a report from the doctor. Family is also in the room, and they start giving you a quick history. Again, 28-month-old male, very healthy, no past medical history, very active little boy. He had been normal over the last few weeks, no illnesses, no colds, no viruses, nothing. And this morning they noted that, or dad, I should say, noted that he just wasn't acting himself. He had breakfast, he acted a little lethargic, a little bit tired, was very thirsty, seemed to be very thirsty. And upon questioning by the flight crew, it was noted that this little boy loves to drink water, drinks water all the time. But this morning in particular, he had 2 bottles of water. And so they were actively potty training him. They placed him on the toilet and they were encouraging him to go to the bathroom. And he started becoming very obtunded, unresponsive, collapsed, and went into a full grand mal type seizure. EMS was accessed, and per the family and EMS, the patient actually had a seizure lasting almost 1 hour. So patient was transported to the local ED. At that time, the seizure had broke. The patient had received a total of 9 milligrams of Valium at that point, and airway had been maintained the entire time with bag valve mask ventilations. The physician tells the flight crew that the blood gases are absolutely horrific, and this is what you have. You have a pH of 6.89, you have a CO2 of 102, you have a bicarb of 13, you have a PO2 of 425, and you have a base excess of negative 15. So the first thing I want to talk about is, before we move on, is let's kind of dissect this blood gas. pH is 6.89. Remember, anything below 7.35, That's our kind of our cutoff to where we're in an uncompensated state, right? And that's on the acidotic side. So 6.89 is a very lethal pH. This kid being as young and healthy, not as lethal as a 50, 60-year-old man or woman, but, still very lethal. So we know that this is an acidotic pH. A CO2 of 102. All right, so this means that this patient has been not breathing adequately. So they're starting to retain CO2. And if you remember, when we've talked about acid-base balance before, most patients are going to present in a partially compensated metabolic acidosis. Their CO2 in a metabolic acidosis most often is going to be actually low because they're actually trying to blow off CO2 in an attempt to protect that pH. We talk about this all the time in our review classes, and the relation between CO2 and pH being for every 10 millimeters of mercury change in CO2, you have an opposite change in pH by 0.08. So in this case, you have a pH of 6.87, and instead of it being compensated, the patient actually blowing off CO2 to protect that pH, we actually have a high CO2, right? So this patient has been retaining CO2. They've obviously been apneic for quite a long time. This patient also has a bicarb of 13, so we definitely have a metabolic derangement going on, right? The metabolic side of the house is in play. Our PO2 of 425, well, remember the oxyhemoglobin dissociation curve. And in a presence of acid, so CO2, low pH, in particular in this case, you're going to move that hemoglobin curve to the right. That means that your affinity for oxygen and hemoglobin, that binding affinity is actually decreased. And hemoglobin does not want anything to do with oxygen, so it's going to dump all of its stores to the tissues. So we have a very high PO2, and also we have a very healthy little boy. And then we have a base excess of -18 that's telling you that there's 15 acids floating around somewhere that we have to try to account for. We have a sodium of 121, okay? We have a chloride of 92. We have a potassium of 4.7. Our BUN and creatinine are normal, so normal kidney functions. We have a normal calcium of 8.7, and we have a normal phosphorus. So if we go back to that acid-base derangement, right? If we have a 6.89 pH acidotic, we have a whole bunch of CO2. We're retaining CO2. It should be compensated, but it's not. We have a metabolic side of the house as far as the bicarb being low. Then this is a mixed disturbance. This isn't something you're going to see very often. And so we have to start asking ourselves, what's causing this? We have a normal, healthy little boy, no history, no meds, no allergies, hasn't been sick, just woke up, was just lethargic, not feeling right, drinking a lot of water, and then all of a sudden collapses within a couple hours and goes into a grand mal seizure. Big red flags. What's going on? Why would this happen? We know kids compensate. They're very resilient. They don't just, peter out like this. So what has caused this severe metabolic acidosis? We're going to try to figure that out. And I think that's the big important thing here is this is one of those cases as critical care providers that it's not that you're just going to go and take this kid and transport this kid. You need to be critical care providers, and you need to try to use differential diagnosis techniques, try to really understand what's going on and see if you can make a change, right? This is not normal. Something's going on that we may be able to solve. Obviously, the sodium being 121, that's a big red flag, and we're going to touch on that. Chloride 92, that's pretty normal. Potassium 4.7, pretty good. BUN and creatinine normal. So I'm happy with everything there. Like I said, the patient had the value, and obviously, with any unresponsive patient, we need to get a blood glucose level. And so they had got a glucose level prior to the flight crew's arrival, and that glucose was 190. The first blood pressure that was reported when the patient arrived at the emergency department was 200/110, with a heart rate about 120, SpO2 in the upper 90s. So let's start looking at some differential diagnosis. Obviously, we want to walk in as a flight crew, transport crew, whatever discipline you are, we need to first establish that this airway is protected. So this physician ended up intubating this child with a 3.5 ET tube. I think a little bit small for that child. When you look at an ET tube like that for a kid, there's lots of different ways to do it. Obviously, I'm a real big believer in the Hantevi pediatric system. If you haven't checked that out, a good friend of mine, Dr. Peter Hantevi, he's got the Hantevi pediatric system, and he's got some really great tools. But if you don't have that, you can use the Broslow tape. You can look at the patient's pinky size. But really, for a kid like that, you're pretty safe to start with about a 4 ET tube. We always want to try to go cuffed if we can. They ended up going uncuffed. So that's always something to kind of consider. I wouldn't say in a patient like this, if this was my patient, would I want to pull the ET tube if it was an uncuffed tube? No, not on a kid that's this sick. I'm going to let them do that at the receiving facility if they choose. But we just need to be cognizant of that. We need to be really aware that they have an uncuffed tube, and that's even a bigger indication of why we would always want to put an NG or OG tube down. Not just because of that, but all kids need an NG or OG tube. So we're going to make sure that ET tube's secured, and we're going to always confirm it with waveform capnography. And so the flight crew did just that. We had the patient had a end-tidal CO2 capnography of approximately 65. So why was there an end-tidal CO2 of 65, but the blood gas showed an CO2 of 102? Well, we have to know when that blood gas was taken. And so based on the blood gas was taken about an hour from the time of the flight crew's arrival. So it could have just been a normal reduction based on BVM, proper airway management, things like that. And I would probably suspect that that's what it would be. This patient isn't going to have any shunts. They're not going to have any dead space ventilation, anything that would cause a huge gradient. We know that gradient is usually between 3 and 5 millimeters of mercury. And we also know that your PCO2 is always going to be the highest number. So your end-tidal CO2 is going to be a great tool. In the 60s starting out, that's a great gauge to kind of identify where the patient's at. So once that ET tube is secured, we need to look at how are you going to transport this patient. What type of IV access does this patient have? The patient apparently had about a 22 gauge IV, had about 150 to 200 mils of fluid from EMS, normal saline, and the flight crew decided to establish a second IV right there at the bedside. It was available. They just did that. So at that point, you got to package your patient, right? Let's just really quickly talk about that. Any pediatric patients you fly, and I would recommend this with even adult patients. Anytime you fly a patient that's a non-trauma patient that has an ET tube in place, whether it's a pediatric patient or an adult patient, always place a C-collar on these patients. And it will really, really help protect that airway. It's going to protect the head from, moving around and flopping around. Anytime you have head movement like that, you have a high probability of possible ET tube displacement. So especially kids with these big, large heads, small bodies, that can cause trauma to the neck, to the cervical, brachial plexus. We don't want anything like that. We don't want airway issues whatsoever. So it's always a good idea to place a C-collar just for that reason, just for airway protection. Obviously, body temperature is a big, big deal. Kids have very, very immature hypothalamuses. Obviously, this little guy being about 28 months, a little bit more mature than a newborn, but based on their body surface area, they just don't regulate their heat like you and I do. So we always have to be worrying about, no matter if it's a summer or winter, make sure that you're regulating their body temperature. Obviously, with any type of illness like this, we need to rule out, is this a febrile issue? Is this patient febrile? Is this patient septic? The flight crew did that. Patient was normal, temperature of 98.5. So no issues there, no real reason to keep the patient uncovered or anything like that. So let's start getting the patient to the aircraft, to the ambulance. Always in this situation, you probably should go out on a pediatric patient. If you hadn't brought the ventilator in, go grab the ventilator. Get the ventilator, bring it inside, and make sure you apply the ventilator. These kids obviously have very weak baby lungs, very susceptible to barotrauma. So we need to, keep that high critical care level of care from bedside to bedside, and that's just important to bring that ventilator in. We're going to talk about ventilator settings here in a few minutes when we get through this. I want to start talking about the differential diagnosis. So, what are some things that could be going on? The patient obviously was normal, had an issue, sudden collapse, grand mal seizure for an hour. We have some big telltale signs here. The first one that kind of stuck out to me when I saw this was a sodium of 120, 121. So that you have to understand, anytime that we have a low sodium, we have a higher susceptibility. As that goes lower and lower, specifically, kids are very susceptible to this. As adults, when we have a potential dilutional hyponatremia, we see this in marathon runners, we see this in athletes, we see this all the time. But really, when you drop below that 120 range, very high probability that these patients are going to go into seizures because of the associated cerebral edema, right? The swelling, the increased ICP, these patients are going to seize. Was that initial blood pressure that the hospital got? Was that a true blood pressure? I don't know. That seems very, very high to me. I wasn't there. I don't know. But that's something obviously I would want to rule out. I want to probably do a couple blood pressures to make sure that is either incorrect or correct. And, obviously if they have a huge amount of ICP, if the cerebral edema was significant enough, you could have a blood pressure that was pretty high like that. So obviously a sodium that's low like that leads me to believe, and that's one of the first things that I would consider, is this a hyponatremia? Is this a dilutional hyponatremia? And you were given kind of a clue in the beginning that this little guy had been drinking quite a bit of water. Although this was very normal for him, this was kind of more in excess this morning. So 2 bottles of water for a 28-month-old, very, very easy. And you have to remember, as far as our sodium, our hemoglobin, all those things, it's based on basically a content of fluid. And so imagine if I had a bottle of water and I filled it with salt and I put maybe 2 tablespoons of salt in there. And then I dumped that water into a larger container and I kept the same amount of salt in, but I added another bottle of water. So your concentration is actually going to be diluted down based on the overall volume of water. And that's exactly what happens in a dilutional hyponatremia like that. So this patient had normal saline by EMS. They had given him almost 200 mils. So the sodium now is after that. We know that normal saline has a sodium level of 155. So how low was that sodium? I would argue it was way below 120. And so is that why they finally broke the seizure? It's just not from the Valium, but because it brought that sodium up. After talking to a few physicians about this, that's probably their diagnosis as far as sodium coming up or breaking the seizure. It wasn't the Valium, it wasn't anything like that. It was just simply giving volume, the normal saline, and that's actually what probably broke the seizure, was bringing that sodium up above that 120 range. So do we raise the sodium? Do we give a 3% hypertonic saline? Again, talking to different physicians, with a transport situation like that and the high susceptibility if you administer 3% normal saline or any hypertonic fluid too rapidly for what's called osmotic demyelination syndrome, I would probably say with our short transports, supportive care would probably be better. Hypertonic saline like that needs to be given very, very slowly over a few days. It needs to be brought up very slowly. And so I would probably wait. I would not hang this if it was me. I would let the receiving facility kind of take a look at that and correct it. Obviously, just based on normal saline administration, the sodium has probably come up just a little bit, enough to kind of stabilize the seizure to where the patient's not in status seizure anymore. And so that kind of brings the argument. Does this patient need volume resuscitation? And with any kid, we always have to identify, does this patient have any potential dehydration? Well, the patient had excessive thirst. So we're going to talk about reasons why that could occur. But we always want to ask the parents, has the patient been urinating appropriately with kids? Have they been having the appropriate amount of diapers, etc.? And per the family, per the flight crew, the family said there was no difference whatsoever. Everything was absolutely normal until this morning. So very, very high probability this is just a dilutional hyponatremia. But why is this patient so acidotic? That's what we need to kind of identify. That's what we need to look at. And this is kind of one of those distractors, because when we see a pH of 6.89, heck, we see a pH of 7.0. That's very, very low. So what could be going on? So let's talk about a few other differential diagnosis possibilities. Another one that's very probable is SI-ADH. And I say that because what if this little guy had a tumor? What if this little guy had a pituitary tumor? What if this little guy had a brain tumor that's undiagnosed? We know that many, many patients every day around the world are diagnosed with cancer, with a brain tumor based on a first-time seizure. Very probable, could happen, could cause that excessive thirst, could cause these symptoms. It could cause the patient to want to drink excessively. It's hard to say, was this patient urinating more? Parents said no, but always something to consider. So is that something we can change? During transport, no. This is just something we can kind of assume, we can talk about, maybe bring it up to the referring and receiving physician. And, this patient's going to ultimately need a CT and probably an MRI to rule that out. Another one is called Reye's syndrome. And this is something that is most often caused from possible ingestion of aspirin, unknown to the family. So could this little boy have gotten a hold of aspirin? Family didn't know, parents didn't know. And a huge subgroup of kids present with this based on an unknown ingestion like this. Another thing is this syndrome often starts when a child is recovering from viral illnesses, such as a flu or chickenpox. Well, we know this patient doesn't have any past medical history, hasn't had any flu-like symptoms, hasn't had chickenpox, hasn't had a respiratory infection, anything like that. So if this was a case, obviously we always need to have a high index of suspicion for everything. This syndrome is going to present with sudden vomiting. Family did state that the patient actually had breakfast and drank some water and did vomit ×1. So there was a sudden vomiting event. Patient laid around for a little bit, and that's when they actually took the little guy and put him on the toilet. He said he had to go to the bathroom, and that's when this collapse actually happened. Lack of energy. Well, he did have a lack of energy when he woke up this morning that was abnormal. He didn't have really interests like he normally did. He was obtunded. Strange behavior. So all these things are something that easily could make you have suspicion of a possible ingestion of aspirin. And then obviously sleepiness. Sleepiness is another common kind of issue associated with a reaction to aspirin and Reye's syndrome. What about DKA? What do we have to have DKA? Well, remember, the big thing with DKA is you're going to have a sugar that's high. We know that when we have a patient with HHN and K, right, in a type 2 diabetes, the sugar is going to be off the charts. And the differential diagnosis between those two is going to be ketones. Well, what do we have to have ketones? And does this patient have ketones? Well, yes, he did. A patient had 3+ urine ketones. In this situation, and for diagnosis of DKA based on the literature, urine ketones, you don't need a blood serum ketone test to diagnose DKA. So a serum ketone test, this was 3 plus, that means it's significant. There was a significant amount of ketones in the urine for this little guy. So the patient had ketones, severely metabolic acidosis. But how does DKA normally present? DKA patients normally present with Kussmaul respirations, with excessive thirst, which this patient has. Kussmaul respirations, obviously, as it progresses to that DKA stage, but also excessive urination. And it's not going to be, just instantaneous like that. They're going to probably note that this is happening. The other thing with kids specifically is that they're going to start losing weight. And oftentimes the parents are going to note that the clothes are starting to fit loose. They're just not eating the same. They almost look like they're, having a starvation type of a situation where the clothes just don't fit like they used to. So how do ketones form? Well, we know that in the human body, we burn sugar, we burn actually glycogen, our glycogen source from our liver. And once we actually start burning through those glycogen stores based on liver function, we start breaking down fatty acids, right? Lipids. And that's a byproduct of that breakdown. And so in DKA, because of the phenomenon of the disease process, we start breaking down those fatty acids because we have a big sugar issue. And that's a byproduct. And so that's one of those things. But could you have ketones in other disease processes? Could you have some false positives? Well, absolutely. This patient had a very long seizure activity. And talking to a few different physicians, they both told me that in a situation where you have a huge stress response like this, obviously kids just shivering in a hypothermic event are going to burn through all their glycogen stores. So you think about a sustained seizure for an hour. Patient woke up that morning, hadn't really had anything to eat, so they're already going to have their glycogen stores pretty much diminished from the fasting of sleeping all night long. So this patient actually had a long status seizure, and very highly likely the ketones are a byproduct of that long sustained seizure. Obviously, you can actually see ketones in starvation. Again, you don't have the glycogen, you don't have the glucose to burn for energy, so the body's going to start breaking down fats. Ketones are going to be a byproduct of that fatty acid breakdown. You can actually have ketones in a severe metabolic acidosis, just based on that severe metabolic acidosis. Again, think about a patient that's hypoperfused. And about 25% of our cardiac output actually goes to our liver to perfuse our liver. And if we have a hypoperfused liver, if we have a patient that is, has a MAP blood pressure that's not sufficient in a shock state like that, they're in metabolic acidosis. Obviously, that could actually happen as well. And then any patients that are dehydrated could cause a false positive as far as ketones. And we know that happens with lactate as well, right? You're going to get these huge lactate levels. You're going to get huge white blood cell count levels. You're going to, it causes a false positive. And we have to look at the big picture in those situations. So I don't really feel like this patient fit the whole DKA. Oftentimes, like I said, you're going to have Kussmaul respirations. I mean, that is a classic sign. You're not going to have a mixed disturbance. Your CO2 is not going to be 102. So I think for me, in the blood sugar was around that 190 range. So why was it high? Why is the blood sugar of 190 high? We have to remember in kids that kids, again, any stress response, and this is kind of one of those pearls that you should take with you. Any kid that you have that you're transporting, I would argue if you do a blood sugar on them, they've been in the hospital, they've been stimulated and messed with, their blood sugar is probably going to be greater than 150, 160, 170. And that's based on a huge surge, huge glycogen release. And so you have to remember that huge surge is going to have to fall. We have to constantly check that blood glucose level. And I've been burned before where I had a blood sugar that was 180 and, waited 15, 20 minutes. The patient just wasn't acting right, checked it again, and it was like 50. So I really, really check these often, 5-10 minutes, if that, max. I'm checking the blood sugar on these kids over and over and over. I just want to make sure. This flight crew did exactly that. They checked their blood sugar at the bedside. Blood sugar was in the 180s. Checked it again in transport. When they started out, it had already dropped down to 108. And they checked it about 10 minutes later, and it was down in the 80s. So what do we do in that situation? Does that match the DKA diagnosis? Well, I would argue no. I think there's a lot of distractors. There's a lot of things that kind of make you think that this could be DKA, with the ketones, with the severe metabolic acidosis. Again, this was a mixed disturbance. All those little things could easily get somebody to think, this could be a DKA. And I think it's a great thought and a great differential diagnosis kind of algorithm to go down. But again, based on all the facts, looking at it from the big picture, I'm not convinced that this is a DKA situation. So what do you do in that situation? You got a blood sugar that falls. Well, we know in kids that we always want to hang a maintenance infusion. This little guy had good urine output, excessive thirst. I don't think it's a good idea to start bolusing this little guy with 20 mils per kilo of volume. We don't want to raise the sodium up too quickly. Based on the blood pressure, based on the heart rate. So let's talk about that. Remember, in kids, 15, 20 years ago, I was taught in pediatrics, heck with the blood pressure, just go off the heart rate. And now I don't know if that was just based on just that entry-level paramedic knowledge, but I know in critical care that's not the case. And so we have two targets that we want to achieve. The first target is we never want a patient to be hypotensive. And that target for a hypotensive kid is 70 plus 2 times the age. So for this little guy being 2 years old, we would never want his systolic blood pressure to drop below 74 systolic. A normal blood pressure for this little guy is going to be 90 plus 2 times the age. And so obviously 94 systolic would be a normal tensive patient. This patient had a blood pressure on EMS arrival, or I should say flight crew arrival, of 110 systolic and a heart rate of approximately 120, which I think is absolutely appropriate. And so, this patient is not tachycardic. This patient is not hypotensive. He's normal tensive. And I think that this patient just needs maintenance fluids. So what maintenance fluids do we give? Well, again, this sugar is dropping. And this is no different than really a patient in DKA, where you want to keep that sugar from falling too quickly, right? That's going to cause a cerebral edema as well. And so we want to do a maintenance infusion. I think the best fluid for this little guy is going to be D5.5. And you need to do the 4-2-1 maintenance infusion calculation. And we know that we always start out with 4 times the first 10 in their weight, kilos in their weight. So this patient is 15 kilos. 4 times 10 is 40. And then the next 10 of their weight. So this patient has an additional 5, being 15 kilograms. 5 times 2 is going to be 10. And we add that to the 40. And so this patient is going to be 50 mils an hour. And that's exactly what this crew did. They hung D5.5, started at 50 mils an hour. And just to kind of give the patient a little bit of sugar, give them a little bit of volume. And again, what's our average transport times? Anywhere from based on the base that you're at, whether you're a ground transport team, critical care transport team, it could be 10 minutes, could be an hour. So this patient's probably only going to get 20 or 30 mils of fluid maximum. But you need to maintain some type of sugar on this kid because it's going to keep dropping and dropping and dropping. Very, very, very important concept. So we have to look at this from how do we treat this patient, right? We've went through the differential diagnosis. We've talked about all the things that it could be, right? We definitely have a potential for dilutional hyponatremia. Everything kind of fits that. We've talked about SIADH and a potential brain tumor. We've talked about, an aspirin ingestion. And then we've talked about potential DKA. So we go back to this patient, we go back to the transport team, and they load the patient up in the helicopter. The patient has been placed on the ventilator in the hospital. And so let's talk about that. How do we treat this patient? Again, this patient has a mixed disturbance. We know the blood gas that they got at the bedside when the little guy came in was what it was. Mixed disturbance, pH of 6.89, CO2 of greater than 100, metabolic with a bicarb approximately 15. So with any kids, right, when we talk about transport ventilators, I think the three top transport ventilators that I see out there teaching all over the place is going to be the LTV 1200 is probably the most popular, just based on the longevity of it, not based on popularity or usability. I think it's a great ventilator. I think the Revel ventilator is going to be number 2 as far as what I hear about the most. And then there's a big surge lately with a Hamilton ventilator. Those are the 3. Obviously, we have the Impact, we have the Eagle, we have Draegers, we have all these different ventilators. But with any kid, you have to understand your ventilator's capabilities. And the capabilities of most transport ventilators is you're never going to be able to deliver a volume of less than 50 mils. So what does that mean? That means that no matter whether you put this patient on a assist control, an SIMV, if you're in volume, the lowest tidal volume you can go with is 50 mils. So if this patient is 15 kilos, and we think about the range of our tidal volume, which is always 6 to 8 mils per kilo, what would our starting tidal volume be? Starting tidal volume is going to be about 90 mils. So there's the argument. Do we go with volume or do we go with pressure? Obviously, the hospitals nowadays have very high-tech, sophisticated ventilators that are really good in volume. They're very safe in volume. 20 years ago, that was not the case. And all kids were always placed on pressure. And I know my employer, any kid, under a year old is going to be placed on pressure control ventilation. And I think that's clinician based. For me, if this was my patient, I would place this patient on pressure control ventilation. I just think it's safer, it's better as far as compliance. You don't have the possible issues, or you have a big reduction in potential barotrauma. And so I would go SIMV. I would let this patient try to overbreathe the ventilator. Patient has healthy lungs. We need to blow off that CO2. Any metabolic acidosis, I think that is absolutely appropriate. And I would set this rate high, right? A normal kid at that age, I would set a rate of 24 to 26. And I would, on this patient, probably go 34 to 36 just to try to blow off that CO2. Again, SIMV, pressure support of probably around 5. I'd start with 5. Remember, if you have a ventilator that is an LTV 1200, a Revel ventilator, the Hamilton ventilator, all 3 of those are called additive. And it's always pressure support over PEEP. And what that means is if you start with a pressure support of 5 and a PEEP of 5, you're actually giving them a pressure support of 10 over 5. Right? So a pressure support of 5, PEEP of 5 is actually a 10 over 5. And we know that in SIMV, that pressure support is only when the patient triggers and takes a spontaneous breath. It's only in play in that aspect. And then I would put a PEEP of, again, 5 and a sensitivity of probably a minimum of 5, just based on transport, vibration, and things like that, because you would not want excessive auto-triggering. What about sedation and pain management? Again, this kid is intubated. We want to let him overbreathe the ventilator, but we've got to keep him comfortable, right? It's very, very uncomfortable to be intubated, uncomfortable to be on the ventilator. So I would go with ketamine on this little guy. Ketamine is going to be great, and I would go with fentanyl, and I would give small aliquots of this every 10 minutes. And so for him, based on most normal dosing, you could go about 15 mics of fentanyl and 15 milligrams of ketamine every 10 to 15 minutes, and I think he'd be very, very safe. I think the ketamine is going to be great as far as hemodynamically giving him a bump. I think he's normal tensive. and I don't think you have any worry about causing any harm. Obviously, with kids in particular, any ketamine administration, you always should worry about that hypersalivation. So always remember, if you start seeing that, you need to give them atropine at the 0.02 milligrams per kilogram range. And obviously look at your protocol and go off that, but that is kind of the standard dose. So this flight crew transported this patient. They gave continuous ketamine, continuous fentanyl, started that D5.5, maintained that blood sugar, arrived at the receiving pediatric hospital. And when they got into the room, they stayed by the bedside for a while, and they reported that an ice stat was actually completed, and blood glucose was also checked. Glucose was about 90, and a new ABG was also checked. That ABG, once the patient got to the receiving facility, was a pH of 7.28, a CO2 of 42, a bicarb of 21, PO2 was almost 500, and a base excess was down to -4. So big change in that blood gas. Sodium was 127. Chloride was 95. All the other labs were about the same. So that's a big change in just about an hour worth of care. So based on that, again, what are some potential causes? Why did this patient become so acidotic? Looking at this case, talking to some physicians, some pediatric intensivists about this is very common. If a kid has a prolonged seizure, and I'm assuming this would be the case in an adult patient as well, but if a patient has a prolonged seizure like that, very, very likely they're going to be severely acidotic like this. Just based on the stress response, this is very common. But just based on the aggressive ventilator management, the high rate, blowing off that CO2, this pH came up significantly. The sodium actually came up to 127 with just normal care. And I think it shows that we don't have to be excessive in our treatments. The physician at the referring facility had recommended 3% normal saline, and the flight crew and the physician had a discussion over that, and I think it was finally decided, let's just wait. And so they waited. They did not establish 3% normal saline. They just wanted to wait and see. The patient was not actively seizing at that point. And again, we don't want to do harm. I think that's one of those unknowns. And if you have a 3, 4, 5 hour transport, it may be completely different. But in a context like this, where you have a 30, 40-minute transport, much different as far as your approach. So, this flight crew dealt with the patient in a way that was more supportive, used the ventilator to try to correct the acid-base derangement, gave D5.5, used good critical thinking, and identified based on the different differential diagnoses. But each differential diagnosis, if you kind of think back, really the approach is going to be the same. And it may not have changed the overall treatment, but I think it's good for us to understand what's going on, because that makes us more prepared for the next patient. So man, I love these types of cases. I love cases where you really have to think, that there's so many different things in play. And I'm not really sure how this patient did. I was told by the flight crew that about 30 minutes after arrival that they did extubate the little guy. Patient was breathing on his own. He was being held by mother, and they did not reintubate. So, I would assume, and again, I don't have the follow-up, but I would assume this was an isolated case of dilutional hyponatremia. This was not a DKA situation. This was not obviously don't know if there was ever an MRI done to rule out any brain tumors or anything like that. I'm assuming there would have been. But this was just an isolated dilutional hyponatremia that causes patients' sodium to drop below that 120 range. And no matter what we do in that situation, we can give all the Valium, the Versed, the Ativan, right? Ativan's always probably best in kids. We can do all that stuff. But what corrected that was bringing that sodium up. just by normal fluid boluses. So that really should always kind of keep that back in the back of your mind, that we've got to be good with our normal 20 mils per kilo in the pre-hospital environment like that. If you're an EMS provider, you're out in the field, or this was a scene flight situation, right? Until you know what's going on, give those boluses. That's not going to raise that sodium up to a level to cause that osmotic demyelination syndrome, but it's going to raise it up enough to where it may just break a seizure in that situation. So I hope you enjoyed this podcast. I really enjoyed kind of researching this case and discussing this with the different pediatric intensivists that I talked to. I think that the crew, did a good job with, communicating with the physician and identifying the different kind of things that they can do to try to correct this underlying issue. And again, the underlying issue probably just being a dilutional hyponatremia. So I want to thank you, and I look forward to meeting you guys at a review class soon. If you haven't checked out the website, you'll see that we've got locations and engagements until the end of the year, and I'm starting to get requests for 2017. So look at that. Always email me. I know I get a lot of emails, and people are emailing me, and I respond, and I love that communication. I love to hear from you. I love to hear your stories, your testimonials, all those things. So keep those coming. And as I said in the beginning of the podcast, if you could please subscribe, that really does help us. If this podcast has changed something in you, if it's made you think differently about education, whatever, if you could do that for me, it really will help others find our podcast. It really helps us with our rankings, keeps us on that front page, and we would really appreciate a review as well. So until next time, I'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.